Hello everyone. So today we'll be discussing trauma from occlusion or TFO. This is a key topic in periodontics, and by the end of this session you will understand what it is, how it happens and how we can manage it. This is Dr. Sugirtha, Reader, Department of Periodontics. So in the introduction we can see the occlusion and periodontal disease. That is, the dynamics of the periodontium to accommodate the forces exerted on the crown is called adaptive capacity. This varies in different persons and the same person at different times. When the occlusal forces exceed the adaptive capacity of the periodontal tissues, the tissue injury results. This resultant injury is termed as trauma from occlusion. That is, our teeth and supporting tissues can adapt to chewing and biting forces, right? So that is called as adaptive capacity. But when those forces go beyond what the tissues can handle, they can damage. And this type of injury it is known as the trauma from occlusion. Okay. So next is definition. So occlusal trauma can be defined as an injury to the attachment apparatus as a result of excessive occlusal force. It can also be called as an occlusal traumatism or trauma from occlusion, traumatogenic occlusion or traumatic occlusion. So the definition means that the ligament, bone and the cementum. So these are the periodontal attachment apparatus, right? So occlusal trauma is injury to the periodontal attachment apparatus that is caused by excessive bite forces. You might also hear all these occlusal traumatism, traumatic occlusion or traumatogenic occlusion all mean the same thing. Okay. So next is the etiology of occlusal trauma. So they say the etiology is mainly the occlusal disharmony, occlusal interference following orthodontic tooth movement, excessive occlusal stress as badly designed partial denture, parafunctional activity example bruxism. That is, the causes can include drifting or tilting of teeth after extractions, high points on fillings or crowns, bite interferences after orthodontics, poorly designed dentures, or habits like grinding and clenching. So all of these can overload the bite and damage the tissues. Next, coming on to the types. So types, the first type depends upon the onset and duration. The second one depends on the cause. So depending on the onset and duration, that is, can be classified as acute trauma from occlusion and chronic trauma from occlusion. So in acute trauma from occlusion, they say it results from the abrupt or sudden changes in the occlusal forces such as that produced by biting on a hard object like olive pit. In addition, it could also be due to iatrogenic factors like faulty restorations and prosthetic appliances. And coming on to the chronic trauma from occlusion. So it is as a result of the gradual changes produced in the periodontium due to tooth wear, drifting movement, extrusion of tooth combined with parafunctional habits such as bruxism and clenching. Depending on the cause. So depending on the cause, it can be classified as primary trauma from occlusion. So primary trauma happens in a healthy periodontium. So the primary trauma happens in a healthy periodontium when forces are too high, like a high filling on a normal tooth. And secondary trauma occurs when those same forces damage a periodontium that is already weakened by the bone loss, as in periodontitis. So coming on to the primary trauma from occlusion, it is a tissue injury which is elicited around the tooth with normal height of the periodontium, that is healthy periodontium. Examples are insertion of high filling, prosthetic appliances, drifting movement or extrusion of teeth into the spaces created by unreplaced missing tooth and orthodontic tooth movement. So the orthodontic tooth movements like a tipping movement or a bodily movement results in trauma from occlusion. So in the tipping movement, there occurs the two zones. The tooth slides towards the zone that is called as the pressure zone and the opposite side called as the tension zone. Next, coming on to the jiggling or the multidirectional forces. So jiggling forces, that is when forces act in multiple directions, it is called jiggling. Okay. So the ligament adapts, mobility increases, but without inflammation, attachment loss does not occur. Occlusal adjustments can restore stability. So jiggling, it combines the pressure and the tension zones, results from jiggling. Zones are characterized by collagen resorption, bone resorption and cementum resorption. So signs of increased vascularity or exudation. Tooth shows progressive mobility. So next is your ligament space that gradually adjusts to new situation. There is no attachment loss and there is increased tooth mobility also. The occlusal adjustments will normalize the width of the periodontal ligament and the teeth will be stabilized with normal mobility. In secondary trauma from occlusion, so in secondary trauma, the bone loss will reduces the tissue's ability to handle the force. So the ligament will widen, mobility increases and tissues adapts to a new functional state. And occlusal adjustments can normalize the ligament width, but bone height stays reduced. So it is secondary trauma from occlusion. So the most important thing to note is that the role of traumatogenic occlusion in periodontal disease. See, excessive occlusal forces do not initiate gingivitis or periodontitis. Excessive occlusal forces is a cofactor in the progression of the periodontitis. It could produce a lesion of occlusal trauma, which could accelerate the progression of the plaque-induced periodontitis. So what I'm trying to say is that excessive occlusal force don't cause periodontitis, but if plaque-induced inflammation is already present, the TFO, that is trauma from occlusion, can accelerate the bone loss and make the damage worse. So, irritation factors or plaque which induces gingivitis that progresses to periodontitis. Traumatizing factors from occlusion causes tissue changes in periodontal ligament space. Next comes your zone of co-destruction. So, zone of co-destruction occurs when a plaque-induced periodontitis occurs in a tooth that also has traumatic occlusion, resulting in severe bone loss, that which is seen in periodontitis alone. So, which means when plaque-induced periodontitis and trauma from occlusion occurs together, they can create a zone of co-destruction. That is an area with more severe bone loss than periodontitis alone. Next, coming on to the reduced and diseased. That is reduced and healthy periodontium. See, in reduced but otherwise healthy periodontium, abnormal forces may increase the mobility, but it won't cause more attachment loss. Okay. So that is the concept of reduced and diseased. Next is the signs and symptoms. So that is in a reduced and diseased periodontium, TFO can worsen the bone loss, which increases the mobility and make the disease progress faster. So coming on to the signs and symptoms. So the common signs includes progressive mobility, pain on chewing, fremitus, wear facets, migration of teeth, fractures, sensitivity, widened ligament space on x-rays, and sometimes angular bone defects or furcation involvement. So coming on to the fremitus test, the fremitus test checks for tooth movement during biting. If the tooth moves when in contact, it is a sign of functional mobility and possible TFO. Radiograph of a mandibular molar with traumatic occlusion. See, a widened periodontal ligament space on mesial surface to the apex with the beginning of the bone loss and furcation. There is also a thickened lamina dura and increased mobility. So, here it says that on x-rays, we may see widened ligament spaces, thickened lamina dura or early furcation, bone loss. And these findings must be confirmed with clinical examination also. So the first molar has a traumatic occlusion here. So causing the bone loss in the furca. So it causes the bone loss in the furca. Clinically, there is no pocket depth nor periodontitis in the furcation, and so the diagnosis is traumatic occlusion, and the treatment is occlusal adjustment to reduce the occlusal loading. Next is your tissue response to occlusal trauma, which occurs in 3 stages. Stage 1 is injury, stage 2 is repair, and stage 3 is adaptation, remodeling of the periodontium. So the tissues react to TFO in all these 3 stages. Injury, it is the initial damage which happens, and repair is the healing attempt, and adaptive remodeling is when tissue change structure to cope with the forces. Normal periodontal ligament with normal occlusal forces showing dense collagen fibers attached to bone and cementum with minimal vascularity. So in a healthy ligament, a dense collagen fiber connects bone and cementum and blood vessels are minimal. Coming on to the stage 1 injury, the first reaction to increased occlusal loading is increased vascularity in the periodontal ligament space. No changes are seen in gingival tissues. With excessive occlusal loading, the collagen fibers will lose their connections between the cementum and bone and blood vessels proliferate. This initial increased vascularity results in a more compressible periodontal ligament and increased clinical mobility. So change in the apical periodontal ligament vascular patterns can also result in increased vasodilation of the pulp with increased sensitivity and pain to hot and cold stimuli secondary to the traumatic occlusion. That is, the injury starts with increased blood flow in the ligament space, collagen fiber loosen, vessels multiply, ligament becomes more compressible, leading to increased mobility and sometimes sensitivity. Traumatic occlusion, after the initial change of increased vascularity, there is a stimulation of the osteoclast that causes bone loss and a widened periodontal ligament space. This also causes increased tooth mobility. So, these are the early changes, like continued excessive forces will trigger the bone resorption, widen the ligament space, reduces the collagen density and disturbs the normal fiber arrangement. In case of an advanced change, further effects of traumatic occlusion are seen, with loss of density of collagen and absence of a functional fiber arrangement. So advanced traumatic occlusion with minimal periodontal ligament tissue. So an advanced plaque-induced periodontitis can rapidly spread apically in this situation. So very little healthy ligament will remain and the plaque-induced periodontitis can spread quickly down the root. Coming on to the stage 2 repair. So the body attempts to repair the injury and restore the periodontium. Repair is stimulated from trauma. The damaged tissues are removed and new connective tissue cells and fibers, bones and cementum are formed. Forces remain traumatic if they exceed the reparative capacity. Buttressing bone formation is a process in which thin bony trabeculae is reinforced with new bone when the bone is resorbed by excessive occlusal forces. There are two types, like within the jaw they are called as central buttressing. On the bone surface it is called peripheral buttressing or lipping. That is a shelf-like thickening of the alveolar margin. So the body may try to reinforce a weakened bone through buttressing, either centrally within the bone or peripherally on its surface. So peripheral buttressing appears as a shelf-like thickening. So at the time of the periodontal surgery, buttressing bone may be removed to restore the normal contour and gingival adaptation. Buttressing bone that is removed during the periodontal surgery. Okay. So to maintain the normal contour of the gingival tissue. Stage 3 is adaptive remodeling. So if repair can't keep pace, the periodontium remodels to handle the forces. The ligament thickens, bone shape changes and the mobility becomes the new normal. Treatment. So the treatment includes occlusal adjustments, SRP and splinting. So if there's inflammation and splinting, if mobility is high. So see, occlusal adjustments, they will reshape the biting forces to distribute the forces evenly and reduce the overload on the specific teeth. Scaling and root planning will remove the plaque and calculus, reduce the inflammation and helps tissues recover alongside the bite correction. So splinting connects mobile teeth so they share the forces, making chewing more comfortable, and it's usually temporary during healing. So what is the key conclusion is that in a healthy gums, heavy forces don't cause attachment loss, but with plaque and inflammation, the TFO can speed up the disease. So that is the conclusion. So bone loss and TFO is an adaptation to altered function, not a sign of primary gum disease. Okay. So effective management means controlling both the bite force and the inflammation at the same time. So the summary is that TFO alone does not cause any periodontitis. It can worsen when plaque is present, and even diagnosis and correction. So the keys to prevention. Okay. So thank you for listening. Thank you.